Welcome. My name is Shannon Trotter. I'm a dermatologist in private practice in the Columbus, Ohio area, as well as an associate program director for the Ohio Health Dermatology Residency Program. And today I'm very excited to talk with you on gene expression profiling for dermatologic cancers, molecular information for personalized management decisions in melanoma, and cutaneous squamous cell carcinoma. It's really an exciting time to talk about gene expression profiling and the opportunity to really individualize patient care based on tumor biology. In today's presentation, we are going to go over clinical decisions in melanoma and discuss DecisionDx-Melanoma in regard to sentinel lymph node biopsy guidance, as well as management and risk of recurrence. We'll also review clinical validity evidence for DecisionDx-Melanoma. And then finally, we'll give a brief overview of DecisionDx-Squamous cell carcinoma and talk about test development and supporting evidence. For DecisionDx-Melanoma, this test can be used to provide information on risk of metastasis that can form decisions on sentinel lymph node biopsy, as well as the intensity of follow-up, surveillance imaging, referral, and adjuvant therapy. DecisionDx-Melanoma is supported by consistent evidence in over 25 publications with greater than 5,700 patients studied. And this includes 4 retrospective as well as 5 prospective clinical validity studies. Of highlight in today's presentation, the 2020 NCCN guidelines recognize that gene expression profiling may provide information on individual risk of recurrence as an adjunct to standard AJCC staging. DecisionDx-Melanoma achieves level 1A evidence classification due to consistent, good quality patient-oriented evidence, including 2 recently published meta-analyses, one of which we will highlight today. This is really your take-home message for today, the slide to really review what should be the key features of this presentation. Now, the stage-only approach that we have for melanoma, it misses patients with aggressive tumor biology. We know in the last decade, new effective therapies for melanoma have made a significant impact on patient outcomes, with evidence suggesting that lower tumor burden and melanoma is associated with better response to modern therapies. Therefore, it's crucial for us to provide appropriate surveillance to high-risk patients to facilitate early detection of melanoma recurrences, to leverage the benefits of lower tumor burden in treatment. We know that most melanoma patients are diagnosed at early stage, 1 or 2. If we look at melanoma deaths by stage at the time of diagnosis, excluding stage 4, 60% of melanoma mortalities are from patients that presented as having no negative disease, with 1 in 4 patients dying that initially presented as stage 1. This speaks to the low sensitivity of the current staging system at being able to identify aggressive disease in early stage patients. And it shows us that our staging is really imperfect. We need to improve prognostic accuracy to determine the most appropriate melanoma management strategy for our patients. Now, when we have a patient that's diagnosed with melanoma, there's 2 questions that we really want to answer for those patients. And DecisionDx-Melanoma informs these 2 important clinical decisions and therefore impacts treatment plans. The 2 questions before us: what's the risk for a positive sentinel lymph node? The other question: what's the risk of recurrence? And this is in regard with follow-up, imaging, and referral decisions. How will we actually approach those? Now, what I want to highlight here at the bottom is the NCCN guidelines in the 2020 version, how it has changed its wording and recommendation for gene expression profiling. The 2020 version guidelines recognize that gene expression profiling may provide information on individual risk of recurrence as an adjunct to standard AJCC staging. And this is different from the previous version, which only recommended gene expression profiling in the context of a clinical trial. This leads us to DecisionDx-Melanoma and why it was developed to help assess risk of recurrence independent from traditional clinical pathological factors using tumor biology. The DecisionDx-Melanoma test is validated in stage 1 through 3 patients based on the expression of 31 genes, 28 discriminatory genes, and 3 controls. Now, this uses standard reverse transcriptase PCR that provides results as either a low risk or high risk of recurrence within 5 years. For stage 1 through 2 patients, the test is subdivided into class 1A and 1B and class 2A and 2B. In these subclassifications, you will see that the majority of patients, around 85%, fall within the extremes of class 1A, or the lowest risk, and class 2B as the highest risk. This slide provides an overview of the substantial body of evidence that has been developed to support the clinical validity and utility of DecisionDx-Melanoma test. Now there's over 5,700 patients included in the validation, prospective, and clinical impact studies that demonstrate the consistent high performance and accuracy of the tests, providing physicians and patients with confidence in the result for follow-up care. And today we will touch on a few of those studies. First, we want to look back at those two questions that I mentioned early on that DecisionDx can help inform. What's the risk of a positive sentinel lymph node and the risk of recurrence? First, we're going to talk about sentinel lymph node. Now, how do we select patients for the sentinel lymph node biopsy surgical procedure? The sentinel lymph node procedure is recommended for melanoma patients based on clinical characteristics of the patient's tumor and a risk of having a positive result that is above 5%. Now, this threshold is based on the sentinel lymph node biopsy false negative rate of 5% that was observed in MSLT1. If you look here at the left-hand side at the chart, you'll see that the T-staging then decides for us who would most likely benefit from having a sentinel lymph node biopsy procedure. If you are a stage T1A, the risk of having a positive sentinel lymph node is less than 5%. And according to the NCCN, this person would not be eligible for a sentinel lymph node biopsy procedure. However, if you're a T1A with high-risk features like mitoses greater than 2, lymphovascular involvement, microstaging, or positive deep margin, that sentinel lymph node positivity increases to 5 to 10%, just like it would for a T1B, and potentially sentinel lymph node biopsy eligibility, it changes. The patient would be eligible, so you could consider or offer a sentinel lymph node biopsy. And of course, for your higher T stages, T2 and above, the sentinel lymph node positivity risk is greater than 10%, and those patients would be eligible, and you would want to consider or offer it to those patients. Now, the use of the threshold, again, is based on the false negative rate of 5% that was observed in MSLT1. The use of this threshold results in an overall rate of sentinel lymph node positivity of around 12%. But what this means is 88% of patients who undergo the sentinel lymph node biopsy procedure will actually have a negative result, and therefore potentially derive little or no benefit from the procedure itself. What I want to talk about is the second prospective cohort that expands the validation of DecisionDx-Melanoma for identifying those at low risk for a positive sentinel lymph node to over 3,000 patients. Now, the study that's listed at the bottom by Dr. Vetto was the first one that was published in 2019. This cohort was a little over 1,400 patients. Now, more recently, there's a second cohort that you'll see in the above section with 1,690 patients that was presented by Cook et al. At the Society of Melanoma Research in 2019 and will be published shortly. These two were taken together to create this combined cohort of a little over 3,000 patients. These analyses evaluate the use of DecisionDx-Melanoma along with age to identify those at low risk for a positive sentinel lymph node. So we're going to look more at the data from this combined cohort. For sentinel lymph node biopsy eligible patients with T1 to T2 tumors, depth less than or equal to 2 millimeters, DecisionDx-Melanoma class 1A predicts low risk of sentinel lymph node positivity. Results of the analysis suggest that in sentinel lymph node biopsy eligible patients with a T1 or T2 melanoma, those with a class 1A DecisionDx-Melanoma result who are 55 years of age or older would fall into a low risk group with a predicted risk of sentinel lymph node biopsy positivity below the 5% threshold established by the guidelines, and that is here highlighted in blue. Now, conversely, any sentinel lymph node eligible patient with a class 1B, 2A, or 2B result is at a higher risk of sentinel lymph node positivity. And you can see here across the board that for all of these groups, it was greater than 10%. And according to NCCN guidelines, sentinel lymph node biopsy should potentially be offered in that group. Now, long-term survival, looking at Dr. Vetto's study and his cohort in the T1 to T2 class 1A patients, demonstrates these patients are at very low risk for metastatic disease or death. The T1, T2 tumors who had a Class 1A test result, regardless of their sentinel lymph node biopsy procedure, are at a very low risk of recurrence, can compare favorably to those who had a Class 1B, 2A, or Class 2B result. And you can see here across the board for melanoma-specific survival, overall survival, distant metastasis-free survival, and recurrence-free survival, that patients perform quite well. Now this is different if you look at the Class 2B patients where they perform poorly, as you might suspect, especially in the sentinel lymph node positive group, where that drops significantly. And the Class 1As also outperform their intermediate group across the board in survival outcomes. Now, how do I use the results from DecisionDx-Melanoma to inform sentinel lymph node biopsy discussions? Well, for patients with T1 to T2 tumors who are eligible for a sentinel lymph node biopsy, a Class 1A result is associated with a risk of positivity below 5%. According to current guidelines, patients who have less than a 5% risk are not recommended to undergo the procedure. Thus, adding information from DecisionDx-Melanoma tests allows a physician to be more selective about who may safely avoid surgical intervention. So as a result, those patients who fall below that threshold could potentially avoid a sentinel lymph node biopsy. By including the DecisionDx-Melanoma result, physician can avoid unnecessary surgical procedures and then focus resources on those high-risk patients. And that actually results in an increased yield from the sentinel lymph node biopsy procedure. Now, if a patient is high risk, Class 2B, or falls within the intermediate class, 1B or 2A, the risk for sentinel lymph node biopsy being positive is greater than or equal to 10%. And according to guidelines for those patients, you could offer the sentinel lymph node biopsy procedure, and they would most likely derive benefit from having the procedure done, since their likelihood of being positive would be greater than or equal to 10%. Now, this is overall very important, looking at these thresholds. Now, as you go forward, why are these important? Well, there's benefits to this. When we look at doing sentinel lymph node biopsy, we want to pick the right population. We want to increase the yield from the sentinel lymph node biopsy procedure. We want to focus resources on patients who are at highest risk, which DecisionDx helps inform us in that decision-making process. And we want to avoid unnecessary surgical procedures in patients that are low risk, the ones that will likely fall below that threshold of 5%. And then overall, this can have an impact on healthcare costs and reduce costs as a whole. Now, we've talked about sentinel lymph node biopsy. We want to switch gears now and talk about our second question. What's the risk of recurrence? And talk about follow-up, imaging, and referral decisions. This next slide looks at DecisionDx-Melanoma as a test that further informs risk obtained by the AJCC 8th edition staging. And this is perhaps the most poignant slide of the presentation today in regard to recurrence, to really show how DecisionDx-Melanoma can build upon our staging system that we currently use. As we talked about earlier as well, this falls in line with current recommendations from the 2020 NCCN guidelines with using gene expression profiling to build upon our current staging system. So if you look at the slide before you, you will see the stage above at the top, stage 1, 2, and 3. And then going along the x-axis, you'll see melanoma-specific survival. What you'll see here now is we'll talk about what is survival for the different stages according to the AJCC. You'll see here for stage 1 in this cohort was around 98%, stage 2 was 90%, and stage 3 was 77%. So now we have population dynamics where based on stage, according to the AJCC, the melanoma-specific survival is spelled out. Now we want to apply DecisionDx to see if we can tease out who is actually going to perform better than their stage says they should, or who may perform worse than their stage says they should, by designating patients as Class 1A or low risk, or Class 2B as high risk. First, let's talk about high risk, or those that were identified as Class 2B. You'll see here for stage 1, melanoma-specific survival, according to the AJCC, was 98%. But for those that were Class 2B or high risk, it dropped to 89.5%, which actually behaves more like a stage 3A. Now in stage 2 patients, according to the AJCC, their survival was around 90%, and those that were class 2B or high risk, it dropped to 84.7%, which is similar to a stage 3B. And finally, for stage 3, AJCC says around 77%, but for those that were high risk or 2B, this dropped to 61.2%, or more like a stage 3C plus patient. So clearly we can see where staging has missed some of those folks that are going to have poorer outcomes than their staging suggests that they will. Now on the flip side, for those that are identified as low risk, how does this impact their melanoma-specific survival? Well, if DecisionDx-Melanoma is applied and they are class 1A result or low risk in this cohort, it actually improved their survival, as you can see across the board. In the stage 1 patient, it went from 98% according to AJCC and increased to 99.6%, more like a stage 1A. For the stage 2 patients, it increased from 90% according to AJCC and went up to greater than 99% as a low-risk class 1A result with DecisionDx, and again, close to stage 1A. And finally, in stage 3, which can be shocking, but a lot of people know in the stage 3 patients, we have patients that perform well. When DecisionDx is applied and they have found the low risk or class 1A patients, their melanoma-specific survival increases from 77% all the way to 94.8%, which is more closely resembling a stage 2A patient. So overall, this really shows how we can build on our staging system by using DecisionDx-Melanoma to tease out those patients who will perform better than our current staging system says they will, and also those who will perform worse. And again, this has impact on how we manage these patients because it's all according to their risk of recurrence and metastasis. Now this next slide kind of presents an overview of consistent results for recurrence risk prediction across validation and performance studies totaling over 2,600 patients. Again, the DecisionDx-Melanoma test has shown these consistent results, and as you can see on this slide, across patient populations, whether archival or prospective, independent or multi-center, the test performs consistently with high accuracy. What we'd like to do in the next few slides is highlight some of the archival group that you will see here that was combined by Gassman over on the left-hand side into 690 patients in one validation cohort and review some of the data from his study. We'll specifically look at different patient populations that he was interested in finding out how DecisionDx performed. The first population we'll look at is the sentinel lymph node negative patients, which is clearly of interest to us for patients that come back sentinel lymph node negative, but then we know some go on to recur or metastasize. Now in this group, the sentinel lymph node negative patients can be further stratified by tumor biology, using DecisionDx-Melanoma to identify patients who are class 2 and at a higher risk for distant metastasis than those identified with sentinel lymph node biopsy negative status alone. So you'll see here in the first chart in the top line, the negative sentinel node biopsy group, there were 54 events that occurred. If you look at that population, the 54 events, and apply DecisionDx to that group, you will see here you have a segregation of class 1 and class 2. And you'll see here in class 2 highlighted in red, 38 out of the 54 events in that sentinel lymph node negative group who had those events, again, were identified as class 2 or high risk. Or rather stated, 70% of sentinel lymph node negative biopsy patients with an event were correctly identified as high risk or class 2 by DecisionDx-Melanoma. Now the next population that Gassman evaluated was the thin tumor group, less than or equal to 1 millimeter. DecisionDx-Melanoma identified patients at high risk of recurrence and distant metastasis in patients within this group. And this is a group that a lot of us are concerned about because we manage these patients primarily, yet we know that some of them go on to recur or metastasize. You'll see in the recurrence-free survival Kaplan-Meier curve, a significant difference in RFS was observed for class 1A versus 2B of 97% versus 65% respectively. And you'll see that highlighted in the chart in the upper right-hand corner. Again, this demonstrates how DecisionDx can pull those groups apart and identify those who are at high risk for recurrence, but in a thin melanoma group. Now, most patients with thin tumors were low risk class 1, but 11% of the thin tumor cohort had a high-risk class 2 result. And among patients with T1b tumors, 14% were highest risk class 2b. Now, if you look at the Cox multivariate analysis that was performed in the study, gene expression profiling class 2b outcome, listed at the bottom and highlighted in orange, is the only factor significantly associated with the risk of recurrence, with a hazard ratio of 9.34, again indicating a much higher risk for class 2b patients compared to the class 1a patients as a result. So overall, you can see in the thin tumor group, DecisionDx can help us pull out those high-risk patients. Now in the next study by Marks et al., the question to be answered here is to talk about, well, how thin is too thin? If we look at Breslow depth, where is DecisionDx-Melanoma most appropriately used? Some people use it on all invasives. However, is there a Breslow depth where it seems to have more meaning or is statistically significant where we can actually see a separation out and overall outcomes of recurrence-free survival and distant metastasis-free survival in a cohort? And that's what the Marks study really set out to accomplish. Now, if you look at the graph before you, you'll see here in the T1 tumor group, again on the y-axis, the predicted cumulative recurrence rate, and going across on the x-axis, your Breslow thickness in millimeters. Now, just looking at the slide here initially, this basically shows the population risk for the general T1 patient population is low, is what we would suspect. But again, we know T1 tumors contribute about 25% of all melanoma deaths. So as we advance the slide, you'll see if we apply DecisionDx, you'll see the punitive risk for class 1A patients, again, how flat that remains, even as increasing Breslow depth occurs, which shows again the strong negative predictive value for this test result. Now for class 2B patients, which you see here, this shows the test can help identify again those at a high risk in the T1 population. And what's really important is the intersection of where the segregation occurs. If you look at the Breslow thickness, the highlighted area is 0.3 or 0.3 millimeters is where you see a separation out with DecisionDx-Melanoma into a class 1A and class 2B result. If you look at those that were less than 0.3 millimeters in the study, there were no events. There was a 100% recurrence-free survival. There was a 100% distant metastasis-free survival in this group. So it shows overall the distinction of 0.3 really being a turning point. And 0.3 to 1.0 millimeter tumors, you can see here the difference between recurrence-free survival and distant metastasis-free survival. Class 2B, recurrence-free survival was 75.5%. And class 1A, they performed better. That increased to 96.8%. For distant metastasis-free survival, the class 1A was at 97.5%, and it dropped to 82.1% in the high risk or class 2B DecisionDx-Melanoma cohort. So you will see here the difference between those two, that actually 0.3 millimeters seems to be the answer to how low do I go, or what might be appropriate for a Breslow thickness to start considering ordering DecisionDx-Melanoma on those patients to see a distinction between class 1 and class 2B results. It doesn't mean, however, you could not order it on patients that have thinner tumors. Some patients do request the test. Some patients like the test because it helps relieve anxiety. There may be other reasons that you have concern that there may be value to adding DecisionDx-Melanoma for your patients. But looking at the evidence strictly in regard to Breslow depth, 0.3 millimeters appears to be a turning point. Now I'd like to switch gears and talk a little bit about meta-analysis of DecisionDx-Melanoma using the largest cohort to date. And again, this is a systematic review, and again, meta-analysis performed to determine the effect of DecisionDx-Melanoma test on risk prediction. And basically this looked at 3 publications with non-overlapping cohorts, and also an unpublished cohort that was included. In total, there were almost 1,500 patients from, again, 4 independent cohorts. And again, the meta-analysis was really looking at the overall effect of DecisionDx-Melanoma in these studies. So this slide summarizes consistent and independent prognostic value of DecisionDx-Melanoma across these studies. If you look here at the top left-hand corner with the Kaplan-Meier's, and then more specifically with the numbers in the chart below that correspond to those Kaplan-Meier's, you will see here a nice separation out for DecisionDx-Melanoma for class 1A, 1B, 2A, and 2B across the board. Class 1A patients have 5-year recurrence-free survival and distant metastasis-free survival of 91.4% and 94.1% respectively. Class 2B patients have a 5-year recurrence-free survival and distant metastasis-free survival of 43.6% and 55.5%. So you see that nice separation out. The table on the right shows a comparison of hazard ratios of recurrence and distant metastasis for the 3 studies and the novel cohort individually as well as an overall. And you will see here for in both groups looking at recurrence-free survival and distant metastasis-free survival, having a class 2B result was associated with almost a 3 times increase with the overall hazard ratio. In the next slide, looking at greenhouse study, class 2B is a risk factor with strongest hazard ratio as well as superior sensitivity and negative predictive value compared to sentinel node biopsy. Again, a class 2B outcome indicates the highest risk for recurrence compared to contemporary staging factors in age, and head-to-head comparison of accuracy metrics for DecisionDx-Melanoma and sentinel node biopsy demonstrate the superior sensitivity and negative predictive value of DecisionDx-Melanoma. If you look here at the left-hand side of the screen, you will see for the gene expression profile class 2B, the hazard ratios are 2.9 and 2.75, again demonstrating the value of class 2B result. On the right-hand side, you'll see DecisionDx-Melanoma achieves better accuracy than sentinel node biopsy. So if we look at sensitivity and negative predictive value for both recurrence-free survival and distant metastasis-free survival, gene expression profiling was superior to sentinel node biopsy in both areas for sensitivity and negative predictive value. Gene expression profiling and sentinel node biopsy, though, were comparable for specificity and positive predictive value. Now, taken together, gene expression profiling and sentinel node biopsy demonstrated in the last column, you can see that the sensitivity and negative predictive value for both recurrence-free survival and distant metastasis-free survival were superior together than either one alone. Now, we've talked a little bit about sentinel node biopsy, and we've also talked about looking at melanoma recurrence and the prognostic utility of DecisionDx. To inform sentinel node biopsy and the decisions we make regarding sentinel node biopsy, DecisionDx-Melanoma is appropriate to use in all eligible T1 to T2 patients. To inform surveillance planning, the test is appropriate to use in patients with tumor thickness of 0.3 millimeters or greater, and in patients with thinner tumors seeking additional reassurance. So you see that here summarized above, that again, you can look at sentinel node biopsy, all eligible T1 to T2 patients, inform the use of sentinel node biopsy. If they are class 1A result, less than 5% sentinel node positivity and favorable prognosis is typically demonstrated. For the class 1B to 2B, greater than 10% sentinel node positivity and higher rates of metastasis are demonstrated. Now looking again for any tumor greater than or equal to 0.3 millimeters, what's the risk for melanoma recurrence? Well, we know now we have a turning point at that Breslow depth of 0.3 millimeters, and this can help inform clinical follow-up in regard to referrals, imaging, or adjuvant therapy, again with class 1A demonstrating the lowest risk and class 2B demonstrating the highest risk. And now in the 2020 version of the NCCN guidelines, they recognize that gene expression profiling may provide information on individual risk of recurrence as an adjunct to standard AJCC staging. So utilizing gene expression profiling allows you to really cater to your patient and look at their individual risk, which is what the NCCN recommends. So DecisionDx-Melanoma, where are they at now? Well, DecisionDx has been performed in 58,000 plus patients and ordered from over 6,800 clinicians. There's been greater than 5,700 patients included in studies, including independent validation. Through the meta-analyses that have been performed, it has achieved a level 1A level of evidence, published in 25 plus peer-reviewed studies, including the 2 meta-analyses. 50% change in management. We've seen this across the board in several studies where physicians and other healthcare providers are changing how they manage their melanoma patients based on the DecisionDx-Melanoma result. And coverage. Medicare covers DecisionDx-Melanoma, as well as multiple private insurers provide coverage. And Castle also has an industry-leading patient assistance program that is beneficial for patients as well. Now we're going to sort of shift to another topic in skin cancer and talk a little bit more about gene expression profiling and squamous cell carcinoma. Over the next few slides, what I'd like to do is talk about DecisionDx-SCC. Now we won't be able to take a deep dive, but I'd like to provide a brief overview to show you what's to come and provide a preview of a test that will be available for your patients that you are concerned that are high risk for metastasis with squamous cell carcinoma. DecisionDx squamous cell carcinoma is indicated for patients with SCC with 1 or more risk factors, and we'll talk more about what those risk factors include. So cutaneous squamous cell carcinoma is an emerging problem within the United States. Managing squamous cell carcinoma is a significant clinical issue, as deaths from SCC are now estimated to exceed those from melanoma. We know that the incidence of SCC is increasing. It's estimated that anywhere between 1 to 2.5 million cases of SCC will actually be diagnosed this year. And because cancer treatment plans and their outcomes are guided by risk for metastasis, just like we showed for melanoma, prognostic accuracy has direct implications on patient management. And unlike melanoma, breast, and other common cancers, SCC patient care has not been personalized with risk predicting gene expression profile tests. And the issue is for us, I think as clinicians, we've all had patients with squamous cell carcinoma that potentially have been more aggressive than we might have suspected. And we know the utility of traditional clinicopathological risk factors is limited by their low positive predictive value. And as you also know, reliance upon clinical and pathological risk factors, again, whether you view these individually, maybe you incorporate them into formal risk assessment systems like NCCN, AJCC, or Brigham or Women's Hospital, is challenging as standard guidelines have not been adopted for the definition of high-risk SCCs across the country. So that's what led to the development of looking at a gene expression profile test for cutaneous squamous cell carcinoma. Can we help identify squamous cell carcinomas that are a high risk for metastasis to help our patients? And of course, can we identify those patients so we can manage them more appropriately? And that's where DecisionDx-SCC stems from. It's indicated for patients with 1 or more risk factors that have cutaneous squamous cell carcinoma. DecisionDx-SCC quantifies the expression of 40 genes for primary tumor using reverse transcriptase PCR. Now there's 34 discriminatory genes included and 6 controls. It applies a validated neural network algorithm. It accurately classifies patients into 3 groups: low, moderate, or high biological risk, as you can see on the right-hand side. Class 1 or low biological risk, less than half the general study population risk. Class 2A, moderate biological risk, with similar risk to the strongest traditional factors. And then Class 2B, high biological risk, with a greater than or equal to 50% risk of metastasis. Now, what are some of the risk factors that are included? Again, DecisionDx-SCC is indicated for patients diagnosed with cutaneous squamous cell carcinoma and 1 or more risk factors. So this is a summary of the risk factors that would be included. In the history and physical examination, this would include tumor size, greater than or equal to 2 centimeters anywhere on the body, tumor location, such as the head, neck, hands, genitals, feet, or pretibial surface, again, areas we refer to as H or M, immunosuppression, a tumor that's rapidly growing, a tumor that has poorly defined borders, a tumor that might occur at the site of prior radiation therapy or chronic inflammation, such as a wound or chronic inflammatory skin disease. If there's neurological symptoms in the region of the tumor, that's also considered a high-risk factor. Now, for surgical and pathology findings, this includes perineural involvement, large defined as greater than or equal to 0.1 millimeters or a named nerve involvement, and small defined as less than 0.1 millimeters in caliber. Now, poorly differentiated tumor histology is also included, as well as depth. Now, depth can be defined as invasion beyond subcutaneous fat, Breslow depth greater than or equal to 2 millimeters, or Clark level greater than or equal to 4. And finally, lymphovascular invasion, as well as aggressive histological subtypes, which can include several different subtypes that are listed below, are all considered high-risk factors. Now, of note, DecisionDx-SCC is not intended for use with locally recurrent tumor tissue. This slide summarizes the published evidence from greater than 1,100 patients and healthcare providers regarding DecisionDx squamous cell carcinoma. Castle Biosciences recently published multiple studies, including data again from over 1,100 patients and healthcare providers. These support the validity and use of DecisionDx-SCC as a valuable prognostic test that can inform decisions about treatment and follow-up care for our patients. You'll see here discovery and development, through validation, and then finally utility. In the next slide, we will review the most recent data for DecisionDx-SCC, highlighting its validation in 420 patients with known 3-year outcomes. So here you will see in Kaplan-Meier on the left for metastasis-free survival for the validation study in 420 patients with high-risk SCC. Now, metastasis was defined as a metastatic event at regional or distant sites. As you can see, there's a separation between patients with Class 1, Class 2A, and Class 2B results. And you'll see the Class 1 in green, the Class 2A in blue, and the Class 2B in red, demonstrated in the Kaplan-Meier. The overall risk of metastasis in this patient cohort was about 15%. Now, as you pull these out for the Class 1, patients with Class 1 result have less than half the metastatic risk seen in the overall study population. That again is your low biological risk. Your Class 2A, or your moderate biological risk, behaves similarly to those with traditional clinicopathologic risk factors like deep invasion or poor differentiation. And then your high risk, or your Class 2B, this identified the most concerning or worrisome SCCs with a greater than or equal to 50% risk of metastasis. The cohort distribution that you can see here kind of goes forward with the results. Again, while the results distribution from routine clinical testing is not known, this large validation study of high-risk SCC revealed that approximately half of patients were Class 1, less than half were Class 2A, and about 1 in 18 had a Class 2B result. DecisionDx-SCC also demonstrates a high positive predictive value while maintaining a high negative predictive value. Again, the high positive predictive value of 52% was demonstrated while maintaining a high negative predictive value of 93%. This improves identification of patients at biologically high or low risk of metastasis, respectively. The next slide shows a suggested use of results of DecisionDx-SCC in clinical practice. And again, it's important to highlight that these are suggested uses that may be implemented into your practice based on using DecisionDx-SCC. DecisionDx-SCC can help inform these management decisions within established guidelines that exist with the NCCN. So on the left-hand side, you have a patient with SCC with one or more risk factors. And the question for us is, what is the risk of metastasis? So you order DecisionDx-SCC, also looking at traditional prognostic risk factors, and then look at the segregation into the different classes to help potentially guide you in management. Now, as you may recall, the designations are low intensity, moderate intensity, and high intensity. And then you could look at both treatment and follow-up plans. And again, the treatment plans may include the following. If a patient's low risk or low intensity, surgery if feasible with a clinical node exam. If they're moderate intensity, surgery if feasible, consider node exam consider nodal imaging and staging, consider oncology referral. If the patient is high intensity, surgery if feasible, nodal imaging and staging, and then consultation with radiation oncology or medical oncology. Now for follow-up plans may include clinical follow-up 1 to 2 times per year with clinical nodal exam, again for your low intensity patient. For your moderate intensity, clinical follow-up 2 to 4 times per year for 3 years, baseline and annual nodal ultrasound/CT for 2 years. And then finally, if you're high intensity, follow-up plan may include clinical follow-up greater than or equal to 4 times per year for 3 years, again a higher intensity because they're a higher risk, baseline and 2 times per year nodal ultrasound/CT for 2 years. So you'll see here in summary, with using DecisionDx-SCC, you may be able to have a suggested use of the results in clinical practice that currently fit within the NCCN guidelines. Again, keep in mind, these are treatment and follow-up plans that are potentials. These are suggestions, but not a hard, fast rule. So DecisionDx-SCC, it's a test that predicts metastatic risk for SCC patients with 1 or more risk factors. Again, classifying patients into 3 different categories based on their biological risk. Class 1A, again, less than half the general study population for metastatic risk. Class 2A adds significant information that identifies risk similar to deep invasion or poor differentiation. And Class 2B, greater than or equal to 50% metastatic risk and multivariate hazard ratio 3 times that of the strongest traditional factors. DecisionDx-SCC complements factors commonly already used for risk assessment in SCC. Again, incorporation of using DecisionDx-SCC with these risk factors really helps put patients into appropriate risk stratification better than traditional risk factors alone. And again, as a follow-up, as we demonstrated in the last slide, DecisionDx-SCC results can help inform management decisions within established guidelines that already exist with the NCCN. This allows you to have a better idea or understanding of your patient's likelihood for metastasis and then develop a treatment plan accordingly. And in summary, DecisionDx-SCC is for use in SCC patients with 1 or more risk factors. In the past few slides, I had an opportunity to talk more with you about gene expression profiling in skin cancer. First, we discussed melanoma, and finally, squamous cell carcinoma. What's important to highlight here is that with advancing treatments for both melanoma and squamous cell, there is value in identifying what our patient's risk is for metastasis or recurrence. This allows us to truly individualize our patient care and really provide an opportunity to show the uniqueness of each patient's cancer and how they should be managed. Castle Biosciences offers patient-focused financial assistance and insurance billing services. Their goal is to ensure all patients have access to DecisionDx-Melanoma and DecisionDx-Squamous Cell Carcinoma tests. They'll submit and track insurance claims on your patient's behalf throughout the billing process and also help with any appeals if necessary. Now, it's important to note that your patient will receive an explanation of benefits from the insurance company, but keep in mind this is not a bill, and that is something you will have to highlight for your patient because it can be confusing when they receive that in the mail. Now, depending upon the plan requirements, Castle may need the patient's assistance with reimbursement and also ask them to sign an appeal consent form. A letter of medical necessity is required to continue with the insurance billing process, and there are templates that are available to help you with that. And you can sign the letter of medical necessity and submit it with the requisition to Castle. And again, Castle offers industry-leading financial assistance program for both insured and uninsured patients to make sure that they get the testing that you would recommend. For more information, please contact Hilary Ferrer. She is the Senior Medical Science Liaison with Castle. I thank you for your time and attention today, and I hope the information received today will better allow you to care for your skin cancer patients.